problem to problem, and now we have Dr. Jordan Shlain, one of my favorite speakers, who's actually going to be talking about a problem that I face daily as a hospitalist. So I'm excited. I'm super excited to hear this. So, yeah.
Well, thank you all for staying late. I brought some props. The 49ers, by the way, are winning 21-3. Spoiler alert. For those of you who are Dallas fans. Okay, so I'm going to throw out a bunch of new concepts today, and there's going to be a lot of information. So bear with me, and let's. Do I have a clicker somewhere? Here. So I can be followed at Dr. Shlain, Dr. Shlain. So the continuity coefficient, what is it? What's going on out there in healthcare? So I'm a primary care doctor. I see patients every day, and am constantly vexed by what everyone's trying to do to solve problems for doctors. I also every day try to put myself in the seat of the patient sitting across from me and try to see what matters to them and what do they want. So I try to always be two people at the same time, which is kind of hard to do, but it's fun. So the continuity coefficient in the football parlance is basically the more handoffs there are, the more fumbles there potentially can be. And in healthcare, as in hospitalists, and even when I send someone to a specialist, the information that I transmit to that person has the opportunity to change between the time I gave it to them and the time they received it. And then there's all the perception issues of what they thought they got and what I thought I gave them. And so ultimately patients, people who go from doctor to doctor throughout the system, they don't want to be fumbled. And we as doctors don't want to fumble them. So I've been trying to construct what is the mechanism by which we can think about continuity, where time is a really critical variable. This is like a person fumbling something themselves, which is not even handing off to somebody or passing to somebody. And so the truth is that, you know, if we're not all put together internally ourselves, we can fumble just by holding on to the thing. So this is the work that I've been working on for quite some time. This is the continuity coefficient. I'm not going to talk about this in great detail. I mean, what all this means. I will break it down for you a little bit later so you can understand how I came up with this. And I did lean on my brother-in-law, who's a professor of engineering at Berkeley, to help me quantify and codify the actual variables in this equation. So health is very complex. It is not a simple thing. It's not something that we can just, it's constant handoff from one doctor to the other because the person is constantly changing. And they have different ideas about different things. So it's not quite as simple as, hey, here's a patient, let me hand him to you, and you exactly receive this exact patient. So the patient will be the football for this particular discussion today. And the patient has multiple complex variables associated with them. And I want to kind of talk about that a little bit. But before I do, I want to talk about the beliefs about healthcare. What is it? So everybody wants the best outcome. When I ask a patient, would you like the best outcome for this particular diagnosis? Universally, the answer is yes. When you ask the doctor, would you like the best outcome for your patient for this particular thing? The answer is universally yes. So you have two people that want the same thing, but yet the same thing doesn't always happen. So that's kind of weird, right? I mean, we're lined up foundationally, but one story up, it starts to fall apart. And I think that, you know, when I think about Stanford Medicine X, and I've been lecturing on healthcare and technology for about 7 years now before it was even really a thing, but healthcare is a people business in need of data. It is not a data business in need of people. And most people out there somehow think that if they got a cool data mousetrap, that it's going to actually be good for people. And it could be, but you got to start with people and try to solve that problem with technology, not develop a technology to try to figure out how you can slot people into it, which is a lot of what's going on around here. And I also say that EMRs and EHRs and PHRs, electronic medical records and personal health records, end in the letter R. And R stands for record, which is historical by definition. And the present tense has new phenomena in it. So what these records do is they give us a interesting glimpse of what happened, but they don't tell us what's happening. And the goal of healthcare is for everybody, doctors anyway, we want to get in front of the claim. And the claim is the thing that happens when a charge occurs. So there's predictive analytics, there's big data, there's all these people that are trying to predict there's a 33% chance you could wind up in the ER. So let's focus on you. Well, that's interesting, but wouldn't it be interesting to know what's going on with you today rather than try to predict what's going on with you today? So the factors of the continuity coefficient is all data are not created equal, right? There are constants, which is fixed data. For example, if you're a female, probability that that's going to change so low that we're going to bake that into the model as a fixed variable. And if you have a history of thyroid disease diagnosed at Stanford in 1983, that's a fixed variable. We can transmit that from one person to the other with high fidelity. Then there are parameters, stable data, right? Which is your hair color. You may go from this to that, you may change it, but probably you don't frequently. It may get gray over time. Your zip code, these are data parameters that move a little bit, but not so much. Then I'm actually coining a new term here today at Stanford Medicine Next, which I'm calling delta data, which is data that's very dynamic and that changes frequently. Your TSH levels from minute to minute, your mood. I got my little Numetra watch, which tells me my sympathetic and sympathetic nervous system on a minute-by-minute basis. And if I get stressed out, it vibrates. And then I tell my kids to stress me out. I show them the sad face. But then my kids don't stress me out, ever. They actually make my face smile. So there's all this delta data that when you try to encode it, that's really where the historical problem happens when someone's trying to get. So that's when you hand off this, and then in a short while, it's that. But you have this. And you're trying to figure out what this is now. And so it becomes this delta data is a concept. Now the last bit of data, another term I'm coining today, which is U data, which is analog data. And this is data that really is the humanistic component of who we are and what matters to us. And these are things like, they're qualitative and they really can't be quantified. Anxiety, fear, preparedness, memory, feelings, bias influences. This is the person that we're taking care of. They cannot be reduced into an equation or an algorithm. And they just can't be. I mean, I deal with people all day long that have various degrees of medical issues, and I have to really look them in the eye. I've got to understand, are they not telling me something? I mean, I had a patient the other day diagnosed with lung cancer, and she says to me, how come you didn't screen me more often? And I said, well, you're 62 and you don't have a smoking history. And her husband looked at me and said, what? She's been smoking for 50 years. And I said, I didn't know that. And she then broke down and said, I was afraid you'd judge me. I was afraid that you may have a worse. And so I was like, well, I can't work with information I don't have. But that goes into this analog U data. Is like, had I been better, maybe I could have unpacked that. And maybe I could have, but you don't really want to call someone a liar or really probe something that they tell you because you want to trust them. So I want to take a brief detour and talk about this concept in engineering, which is called mediating representation. This is what? Okay, this is a pen and a cap to a pen. And I would argue that I could have a conversation with every single person here about what that is, and we could have a conversation where we build upon what this is. And so in order to have a meaningful conversation between people, we have to be able to mediate what is being represented. Right? And so it's an engineering term. I can send you some papers on it later. And so when something is represented that we can mediate, we can actually build a space shuttle because we're having to deal with this part. Do we all agree that this part is that? Yes. Then we add that part on top of that part. Will it do that? Well, guess what? What's that? If I have a conversation with everybody here about that, I guarantee you everyone's got a different idea about what that is. And we're going to have a really hard time having a meaningful, deep conversation about this. We could, but every person here will have a different conversation with each person here because we can't mediate this representation. And people look more like this than this. Everyone's unique. So healthcare is not binary. It is trinary. And what I mean by trinary is there are zeros, ones, and U's. And the U is that analog bit that I was referring to earlier. Which is what makes digital health interesting but insufficient because it's a people business. It's not, it's a people profession. I'm loath to call it a business. And it's really adding the humanities and intercalating those with digital representations. Because if I take this football here, if I make a 3D digital representation and an EMR of you, Anil, and I basically try to hand that off, and I think of a handoff as, I'm going to do a sign out to you. Here's my sign out. I'm giving you all the color, because he's a doctor and a hospitalist. The verbal handoff gives him tone and color of how I feel about Anil and what I'm concerned about. It's not just, here's the facts, right? So that's a handoff. A pass is when I tell him nothing and all he has to do is look at the chart and he's got to figure out who Anil is. And a pass has far greater data decay in terms of understanding who Anil is than a handoff. So as part of that big equation I showed you earlier, there are handoffs and there are passes. And so we prefer handoffs. But what we really prefer is I don't hand it off to anybody. I just hold on to it. And I'm Anil's doctor, and if I send Anil to somebody else, they tell me what they want to do, and I collaborate with them because I know Anil better than anybody. You. It's you. Yeah, it's simple as that. So the you here is just really you, and I didn't really have a better way to represent it, and I thought it was a good character to represent you. And by the way, that pen. By the way, if I was doing a sign, it would be a 37-year-old man with no medical problems and pink eye. We can all agree that that's the simple. But that image is a 67-year-old woman with diabetes, hypertension. She just got divorced. She's been arrested twice. She lives in a trailer park. She's getting food stamps. And I can go on and on and on about that story. And that's why those patients, and those are the ones that cost all the money. And by the way, people talk about readmissions. I talk about someone that just wound up back in the hospital, and that sucks for them. But we have distilled it down into this concept of a readmission. It's this abstract concept which does not actually layer into the fact that that's a human in there that didn't really want to be a readmission. And so we actually have this weird language that we talk about with. And so the two core principles that drive you data, and this is, again, Jordan's theory on human operating system, is that all we care about, every single one of us, is to be valued and included. And those two gears, if we feel valued and included, will engender trust. So if we have trust, which is I think you were saying trust, everyone's been talking about trust. Trust is this golden thing. Now, how we communicate is the critical aspect of that trust. So where are we going here? Okay, so let's talk about being human for a second. So human biases, of which there are many, many biases. I'm most fascinated by the fundamental attribution error, otherwise known as the correspondence bias. Anybody know what that is? It's a pillar of social science, which was discovered, or not discovered, but kind of founded by a Dr. Lee here at Stanford in 1967. And I'll read it to you because I don't want to mess it up. But the fundamental attribution error, and we all do this, by the way, I mean, is a tendency to place undue emphasis on internal characteristics to explain someone else's behavior to a given situation rather than considering external factors. So another way of saying it more simply is we judge other people differently than we do ourselves because we judge ourselves on our intentions and we judge others on their behaviors. And a crystal clear example of this is personal responsibility for obese people. Well, guess what? We're attributing that it's their choice. But if 80% of the food they buy has added sugar in it and they didn't know, if there's an externality where they have no choice, are they personally responsible? No, but we're going to attribute that to them, right? And so this happens all day long. And oh, by the way, there are 20 other biases about being human. And this is what makes us, human, and our foibles and why we do stupid stuff and start wars and, and get into domestic violence and all the stuff that goes on with humanity. So this is the really hard part because you can digitize all day long and as much as you want, but you're dealing with people that have all these. And by the way, we have them too. Doctors have them too. Nurses have them too. Everybody has them. So we don't just think about the patient that has these that may not be reporting stuff or may be judging. We do it too. So then there's the statistical biases, by the way. Then when you do all the analytics and the big data, and so then you have all these statistical biases. So this stuff isn't easy. And when people can come out and you say, I've reduced the problem to this, I've got an algorithm and an app, it's just not, which I'll do later, by the way. I'll talk about an algorithm and an app. But it's just really, really complex stuff. And what I really am trying to impart here is that healthcare is not simple at all. And I think that computers and technology can eliminate a lot of these biases or at least shrink them down so that we don't have all the human statistical biases. So these are the factors of the continuity coefficient, and this is that big equation I showed you earlier. I'm happy to talk about it afterwards. But there's a volatility or variance part of the equation which talks about how much delta data there is within a certain patient. There's the number of handoffs, number of passes, the impact of a pass, the impact of a handoff, the number of variables. And I'm going to kind of go quickly into taking a continuity coefficient. Now, this is all hypothetical. Jordan Shlain invented this. So it is yet to be scientifically proven, but it's a framework for which I intend to prove this over time. So, or try to. So this is the number of handoffs you can see in the colors. This is the pieces of data. So with each piece of data, things get far more complex when you're handing them off. Now this is with a continuity coefficient, for my equation, of 0.95. So you're pretty close to maintaining continuity. So with no handoffs, you can see that the continuity coefficient stays the same at the top. And with each piece of data, it rapidly declines, especially with additional handoffs. The other cut of that same thing is the number of handoffs is the x-axis, and the information continuity is here. Same coefficient of 0.095, and you can see with no handoffs, the continuity coefficient is 0. The fall off is less for handoffs depending on how many data elements you're handing off. And I'm just trying to describe that being a patient and going through the healthcare system, your data degrades, decays, changes, evolves, your feelings do, and I didn't even add you data into these equations. And so what can we really influence as a doctor trying to work with our patients? I mean, it's just the center of the Venn. I mean, we can do all the digital processes we want right here to like make things better and easier, but we got to deal with people and culture. And those are things that digital health can attempt to scratch the surface of, but it's complex. So a model of patient engagement, this is a study done by Blue Cross Blue Shield, and I'll kind of fly through this really quickly, but it just shows that if you have continuity and you have connectedness, that yields empowerment. And once patients feel empowered, and they feel informed, this is being valued and included again, they're comfortable asking questions, they have trust. And if you can form a form of communication, you'll have engagement. And so engagement is really this holy grail, and they have to engage with themselves. So now I want to talk about what do patients want, and I would like people to agree or disagree in real time with me on this. But I think that patients want to live their life with minimal impact of illness, and they don't really want to go into the healthcare system at all. Nobody wants to come see me, unless they want Viagra, maybe. And so they want to have trust in their medical team. Right? You want to have that trust. You want to have a convenient communication channel, and you want to get answers and direction and support. I mean, you guys may add some other things, but I think I've been thinking about this, trying to distill down what patients want. So I'm going to pivot a little bit and go to Hollywood, right? So as a hospitalist who's seen pneumonia, this guy has seen the pneumonia movie, which is someone comes in, they're sick. He knows exactly what's going to happen over the next 4 days, pretty much. He knows that if this happens, then he's got to do that, and he wants the movie to end good. So each individual is the main actor in their healthcare movie, but they've never seen the movie before. It's the first time you got pneumonia, and you're sick. You can't really know what the best thing is, and all the digital stuff you can get, you're still going to lean on him, who's going to take care of you in the hospital, and you hope that he's seen this movie so many times that he's got great pattern recognition that he will prevent bad things from happening. And the truth is in the real world, when you're not in the hospital and you're out in the outpatient world where most healthcare happens, who's your producer, who's your director, who's your supporting cast, right? How do you get to find that pattern recognition for very specific conditions to get some guidance and support throughout your journey? Or, you want your healthcare movie to end well. So what do doctors want? And you can push back on me on this one too. We want to practice without hassles, right? We would like less screens, I think, in our lives. We want actionable information. Like just giving me a pile of data, kind of helpful, but not really. Because then I got to figure out what else I need to, at some point it becomes actionable, but just don't give me piles of data. I want payment models that make sense because I don't like the transactional model of fee for service. The fee for value model or this ACO model is good, but how can I be accountable if you're not accountable? That doesn't make sense. I want to decrease my malpractice risk, and I'd like my reputation and respect to not fail. Yes, sir. That's a given. Sorry, but yes, of course. But I'll add that. So I just held that truth to be self-evident. So what do patients don't want, right? I don't think they want to have the internet as their first responder. I mean, I think that they have come to settle that that's the case, but I don't think that's the desire. I think you'd like to have some other mechanism of somebody you trust. So we trust Dr. Google for some reason because the front door is always open at Dr. Google, but Dr. Google is an oncologist. Because when you go to Dr. Google, you have anxiety. And when you have anxiety, the last thing you want to see is cancer on that list. And cancer is always on that list. And so then Dr. Google is an oncologist. Patients don't want bad outcomes that could have been prevented. And they don't want to be alone, disconnected, and undervalued. And again, it goes back down to the humanities here. So what we need is a continuously learning clinical operating system. that is underpinned by an empathetic narrative and a mobile enhanced actionable information. So I've spent the last 7 years in my office trying to build this concept where continuity all comes together. And it's called Healthloop, for those of you who haven't heard it. I mean, I've been trying to build this and trying to get people to pay attention to me for years, and it was only until last year that someone wrote a $10 million check and said, okay, go, because it looks interesting. And so this is now a going concern, and it's really interesting, and I'm glad that someone believed in me, because otherwise I was just going to be, the guy that had an idea that went nowhere. And the goal is to treat each patient like the most important person. I'm trying to take on all these things that I've just explained to you. And so so we've built this patient continuity engine, which basically writes movies. We write movies with doctors in a consultative model, because you've seen the movie so many times, and the common things are common. It's the variations that are variable, but that's only so good. So you need to have relevant contextual communications, right? You need to get a message that is proactive, asynchronous, contextual, relevant, and makes you feel like you're valued and included. It says, hey, you're post-op day 3 or you're pneumonia day 6. Here's some things that you're probably thinking about, because all humans think about this on this day. Here's some things you need to know. And by the way, tell me how you're doing, because I want to make sure that something doesn't happen that I don't know. So you get to be part of the actor in your movie, and you get to write the lines that then, and this is the you part. This is the part where you get the human component in there, and you can track over time how the you is changing while you're monitoring all these variables. It builds trust. It's exception-based alerts. It gives physician action-oriented information, which I call Theta data, which will be a lecture for another time. And it enables you data feedback, and it decreases anxiety, like being valued included, like I said. So just real briefly, and again, this is not a commercial for the product. This is just the summary of all my work over the last 7 years. Is patients will get a check-in by email. Dr. Shlain would like to check in with you today. That's all it says. No PHI, nothing. You check in, you go back, and in here, and this is kind of a crappy representation, but you start here, and it says, hey, look, it tells you where you are. It gives you a sense of framework. Your post-op day 3, your pneumonia day 6. Here's what's been happening with you. Here's what you need to know. Here's the resource box for all the questions that people like you have. And then let me ask you 7 questions today. And a lot of these, I can unpack the stuff we're learning is crazy interesting. Now, this is what I get every day. So while we've been here, I checked in with 40 people. I had 40 visits with patients where they felt like they met me online on their iPhone. The questions were asked of them. Information was given back to me, and it kind of creates this exception-based model. So when I checked in with my 25 people today, this is actually an old day, one person popped up. I can log in here, go right to that person, see exactly why they're going off script on their movie and they're about to have a bad outcome. And I can look back in time to understand the you, to see what's going on with them, and I can also track and trend all the other things that I cared about. And so the results are pretty cool. 78%, so someone talked about Net Promoter Score. Our Net Promoter Score is, I think, 70-something, which I didn't even know what a Net Promoter Score was until last few months ago. But we're like higher than Apple and Google, it turns out, because people who use this want to refer their doctor to whatever the Net Promoter Score, I'm a little bit beyond that, though, is 78% check in 100% of the time. And there's a bunch of people that check in less than. So people love this stuff. They're eating it up. And we find that 87% of the people said, I avoided an office visit as a result of being checked in and being supported and cared for throughout my journey or throughout my movie. And 60%, we've seen the phones are being silenced. People don't use the phone anymore. The telephone, not the computer phone. Because ultimately, if you can get the answer to your question, well, you don't need to get on the phone and wait. And so that creates a great customer experience. And we're seeing all the doctors using this get 5-star Yelp reviews and 5-star health grade reviews. It's all of a sudden a reputation tool, which was not what I intended to build, but it's an interesting epiphenomenon as a result of that. And this is, kind of unlocking the data liquidity, right? This is what the doctor sees. Here are my patients. And so, you get your staff involved. The patients get their family involved. You can get caregivers involved. And this just kind of lets you know, hey, so rather than going back to the record versus what's happening now, you can now drill into today. What's happening today with this person on a Saturday or a Sunday? I mean, we had a doctor, the orthopedistic at, I can't say the name of the place, but somewhere in LA, and he was visiting his folks in Boston. He checked in on a Saturday, reached out to the patient, solved the problem. He sent us this email saying, I can't believe this is amazing. So you're able to really kind of pinpoint. So I say it's population management, with the U being YOU. And population. So it's not like looking at a whole population. I only care about, doctors can only take care of one person at a time. They can't take care of 3,000 people at a time. So give me the tools to make this exception-based. Anyway, this is the napkin of which I started my continuity coefficient on at a bar. Thank you.